So Professor Roth, thank you so much for joining us today, and I'm going to welcome you to the stage.
So yes, thank you to the organizers of this conference, which has been really wonderful so far. I'm assuming everybody can hear me. Okay. I also just want to say something about my slides. They are as basic as possible because I decided this is a very artsy group and I'm not going to even try. Oh. So I'm just letting you know that right now. So I'm going to present some ongoing work that first began when I had a master's student named Zoe Channon, who is now at the University of Michigan getting her PhD in sociology. I want to give her full credit for steering me towards my current work on the politics of fighting for more resources and less stigma for those who face opioid use disorder. And I'll try to make my path to this work a bit clearer. When I was getting my PhD in sociology, I participated in ACT UP LA in the early 1990s, wrote an article about the women's caucus of that group and gender issues, and then many years later, I wrote a book about the group, and that's the title of the book and the title photograph, the cover photograph. In my archival research on ACT UP LA, I found that the question of whether to support a then illegal needle exchange was one of the issues that created splits within the group that were impossible for the group to recover from. I wanted to know more about the history of needle exchange programs in the US, and as I was finishing the book, I turned to Zoe, who was doing an independent study with me, and who crucially was in recovery herself. Zoe told me about what turned out to be Truth Farm's first Trail of Truth event, and Alexis will have plenty to tell you about what Truth Farm is. The Trail of Truth event was a rally and a march memorializing the deaths of loved ones to overdoses, and Zoe had just lost a friend, in fact, a recent graduate of BU to an overdose. So what you see here is from August 31st, 2016, when about 100 people came to the Trail of Truth rally in downtown Binghamton, New York. At the outset of the rally, a row of tombstones made out of poster board lined a retaining wall with the birth and death dates and photos of overdose victims written on each one. After a series of speakers who called for resources to fight the opioid epidemic, family members and friends were asked to carry their tombstones a short walk away to the front of the Broome County Government Plaza complex, and then to lie in front of the tombstone and have their bodies outlined in chalk on the sidewalk, and the hairs on the back of my neck stood up, right? So this tactic of outlining a body to temporarily disrupt the everyday visual field of passersby with a reminder of unjust deaths is one that was used by the anti-AIDS direct action movement of the 1980s and 1990s, where activists staged die-ins to protest the lack of government response to the AIDS crisis and then outlined their bodies on the ground. And that's the photo on the right. You can see the captions. Outlining a body in chalk was also a tactic used by other movements, the anti-rape movement and the anti-nuclear movement, to name two examples, and I'm certain there are more. A short while later, at a different community rally about deaths in the Broome County Jail, a very cold February day, if I remember right, I asked Alexis, and this is how I asked Alexis because she's tall and I had to get permission, for permission to attend Truth Farm meetings and take notes. And Alexis said, and this is a very near quote, "You can come to any meetings you want to for any reason." I've been involved with Truth Farm since then and have received some funding to expand the research beyond an ethnography of the single organization, Truth Farm, to thinking about the politics of anti-opioid activism in central New York, and perhaps more broadly still. So I'm not going to cite stats on the contours of the opioid epidemic, since many people here are likely to know about those contours, and are also likely keenly aware that the COVID-19 pandemic has only worsened the public health problem of overdose deaths. I will rather focus on what I see as the connections between anti-AIDS activism and anti-opioid harm reduction activism. That connection is both embodied and in the social movement visual world ether. How else would Truth Farm have happened upon the same kinds of expression of loss that anti-AIDS activists used decades before? I would suggest that there is a kind of vocabulary here, although not one I have formally or exhaustively mined. I'll leave that to others. I'm a sociologist, and so when I think about the politics of grassroots organizing, I think of it in terms of social structure, by which I mean institutions at all levels, as well as the structure of interaction. I'll treat two concepts here broadly that have influenced my work both on ACT UP LA and the current politics of the opioid epidemic in central New York. Per the slide, the first concept I'll focus on is stigma, which we've heard plenty about so far today. And the second is the notion of social movement fields, which I do not think we have heard anything about. So just as it remains impossible to talk about the politics of AIDS without confronting the reality of stigma, one can't understand the politics of harm reduction and anti-opioid epidemic activism without addressing how stigma shapes political efforts inside and outside of established institutions. The activists who argue for more awareness of the epidemic and better resources for dealing with it, they deal with constant, draining stigmatization by the larger community. And I mean all elements of the community, including other family members, strangers, healthcare and social service providers, politicians, sheriffs, and feel free to add your favorites to the list. Those who deal with stigma, who are disqualified from full social acceptance, to use one of Irving Goffman's succinct definitions from his 1963 book. Those who deal with stigma face continued challenges to the legitimacy of their cause. Stigma creates the stigmatized as people reduced in our minds from a whole and usual person to a tainted, discounted one. Anti-opioid epidemic activists face stigma as those with substance use disorder cannot count on the public, the government, or social service health professionals to see them as whole people. As a movement scholar, I will add that stigma is implicated in why certain groups are kept out of the body politic or excluded from institutions. And in the case of drug use, there are many instances in which the exclusion of those with substance use disorder is seen by the larger community as justified. And you can hear the words used about drug users to dismiss their wholeness. They made or make bad choices. They break the law just by using. They steal. They don't stick to their recovery plans. They are a drain on the community. Who's paying for the Narcan, and onward and onward. Families who have lost loved ones to SUD cover the cause of the person's death and confront a distinct lack of sympathy when they are open about that cause of death. Families and friends who are dealing with loved ones who have substance use disorder are themselves stigmatized just for trying to live with that person. The common sense, and I put common sense in quotes, is that they should practice tough love and have the loved one hit rock bottom and then pick themselves up by themselves. And if family members or friends themselves have a substance use issue, the stigma piles up even higher and even residual sympathy fizzles away. Stigma is thus a structural factor that shapes how activists and institutional actors work to combat substance use disorder. In calling stigma structural, I'm not arguing that it is unerasable, so I want to be clear about that. It can be shifted, changed, diminished, but not without effort and not without direct attack. Okay, we got fields up there. The second concept that influences how I study activism, whether it's about public health issues or other matters, is that of the social movement field. The idea of a social movement operating in fields was first put forward by Raka Ray in her 1999 book, Fields of Protest. She defines a social movement field as a structural, unequal, and socially constructed environment within which organizations are embedded and to which organizations and activists constantly respond. A field encompasses the other political players, movement organizations, political parties, state structures that social movement actors confront. A local field also has a prevailing political culture. That is, a way that actors make and respond to claims. Why is the concept a good one for me? I think it helps us map out who is consequential in making decisions about how to organize, where money goes, where the obstacles are, and why activists make the decisions about organizing that they do. A local social movement field presents both opportunities and challenges, and fields in the next town or the next county can look very different, even if they are close by. And counties, of course, are important purveyors of public health. With the help of a couple of graduate students, now Dr. Nilofer Ekelin, yay, who's at the University of Florida, and Ella Friday, who's finishing up at BU, I should say we, have been looking for ways to understand responses to the opioid epidemic in different central New York counties, specifically Broome County, where Binghamton is, Tompkins, where Ithaca is, and Tioga County, where not much is, including no hospital within the county lines. And we have found that politics matter in terms of whether or not Democrats or Republicans sit in public offices. It's kind of a leftist truism that there are no differences between the major parties, and I'm sorry, I have to get my sort of neck in there. The Republican Party, et cetera, but party affiliations of the people actually elected to do county business matters, as do the political allegiances of the residents of the county. It really matters who is in office, just as it really matters who is doing the public pressure and whether or not alliances are made or even can be made in the social movement field. One thing I took from my research on ACT UP LA is just how important it was for local activists to be able to press local politicians, especially those on the county level responsible for public health, to hear their demands and act. There are many stories out there about local campaigns who get changes made at the local level. These campaigns are understudied and they're not well understood. Okay, there we go. As an example, and this is just an example, I'm not marking it as a paragon or something like that, but it's an interesting example. I'll turn to one organization that operates in central New York and that has direct links to the anti-AIDS activism and current harm reduction activism. In 2019, Zoe conducted an interview with John Barry, who was and is the executive director of Southern Tier AIDS Program, or STAP, which started in the early 1990s to battle AIDS by providing services, which it still does, and which also runs a needle exchange program and is part of a coalition of groups seeking aid from the state being another kind of social movement field, to advance harm reduction services available to drug users. When Zoe asked about connections between anti-AIDS organizations and harm reduction activism, Barry responded specifically about the local shape of the AIDS epidemic in central New York. I think folks don't realize historically that even at the very beginning of the AIDS epidemic, like more than half of the folks who were getting infected every year were getting infected because they shared injection equipment. So this has been a problem for forever. I always find myself scratching my head and being like, why is it a problem today and it wasn't a problem in 1978 or 82 or, because when I was here in 91 as a case manager, I was working with like 50 people at a time, and I can tell you from my own personal experience with my caseloads, it's like more than half the people that I worked with were folks who had been using injection drugs. In talking to Zoe about STAP's needle exchange program and its harm reduction activism, Barry does see some change in the local reception to harm reduction ideas. I think people are more open to it, meaning harm reduction. There are still pockets of resistance, but I guess I should be happy about that we're at a place where what we're doing is kind of ferreting out the pockets of resistance rather than being globally just told, that won't work, go away. I just find myself getting annoyed when you get to be an old man like me and you've been doing this kind of work for decades, you find yourself having to go over the same territory again, same territory over and over again. So I haven't done all the research about local connections, place by place, across this great United States, between activist organizations founded to combat AIDS and links to current harm reduction activism, but I have to think these connections exist in many places, and again, they're untold stories. To the extent that we can recapture that history, we can draw the lines between anti-AIDS activism and current harm reduction activism even brighter. I'm not saying that because I'm trying to wish these connections into existence. I'm saying that because we know they exist, and this conference focus is yet another piece of evidence that we need to make these histories known. In conclusion, and on the topic of making histories known, it is hard work, I believe, and we'll put this belief to a paper someday, that for most social movements, the price of success of a social movement, influencing research distribution, changing the conversation, making new claims and claimants intelligible to the people and to power. The success of the social movement is often, always, predicated on the erasure of the social movement itself. There are exceptions to this statement, but really not too many. Black civil rights movement is preserved in parts due to federal actions. The feminist movements of the post-war period that shook up American society are understood in parts as well. It seems to me that my students, who are mostly born in the 21st century, have no idea that HIV wasn't always treatable, that HIV disease didn't always have attractive people appearing in high production value commercials. I watch a lot of Bravo, touting medications that make you undetectable. They don't know, not just because they are young, but because to talk to them about the history of direct anti-AIDS action changes the story about how things came to be better through hard work, mourning, disruptive behavior, and radical action. I would say that the fight against the stigma placed on drug users and the fight for a just distribution of resources through harm reduction measures could end up in the same place of forgetting as a price of success. And I say, let's not let that happen.
I'm now excited to welcome Dr. Diane Morse. Dr. Morse is a researcher, medical educator, and practicing internal medicine doctor. She's also an associate professor at the University of Rochester Departments of Psychiatry and Medicine. She investigates implementation of trauma-specific motivational, social media, and peer community health worker strategies to increase needed services for women who are justice involved, men and women who are justice involved and who have substance disorders, and those who are at risk of HIV, including individuals who are on probation, in drug treatment court, or recently released from incarceration. Her work has been funded by institutions including the National Institutes of Health, NIH, the Substance Abuse Mental Health Service Administration, and the Health and Human Services. I work as a physician strong, so I see patients who come in for the hospital, and I have the immense privilege and pleasure to see patients that Dr. Morse has treated in the outpatient setting. And I meet them wherever they are in their journey or in their path, and whatever relations they have with a substance they may be using at that point of time or not. And hearing them talk about Dr. Morse and the treatment she offers, may we all be seen that way by the people we serve. And so it's a great privilege to welcome you here today. Thank you, Dr. Morse.
I just want to start with asking a question. How many people here have a friend or family member or yourself has been either incarcerated or involved in some way in the criminal legal system? And myself as well. Thank you. So it's a common issue. And similar to what we've talked about before, there's a lot of stigma related to it. I actually want to say that the terminology that we're being asked to use now, and I apologize for not correcting it in my bio, is not to use the word justice because it's not considered to be a just system. So a terminology that I know may sound uncomfortable, but we're being asked to use now, criminal legal system. So that's what I'm training myself to do right now, and continuing to watch for and listen for what are recommended terminologies. This is our program, the Women's Initiative Supporting Health. And so there are a lot of people, as we just talked about, who are involved in the, and I'm sorry, I'm still changing my slides, so I messed up here. So in the United States, total of 2.3 million, that's most recent. But looking again at those numbers, a quarter of men, black men in the United States will experience an arrest. I'm just going to highlight a few things. And these numbers, of course, are very large. Prison, larger than jail. And many on supervision, which is probation and parole. And prison is longer than jail. But anyway, we'll talk more about it. I could go on this for a long time, but I'm just going to focus. So why do we focus on incarcerated women? So actually the majority of people who are incarcerated are men, but women are still the fastest growing incarcerated population. And because they're the minority of people who are incarcerated, the services tend to be more for men. So I'm just going to give you an example of when I was talking with people at the jail, people who run things at the jail. They told me a story of, that they called all the men down to see their attorneys, but they didn't call the women down to see their attorneys because they didn't have enough time and space to do both, and much more of them were men. That's just one example. There's also evidence that Women have harsher sentences than men, and for the same crimes, and this can relate to more stigma against women because they're expected to behave nicely, particularly, mothers. And women there are a lot of women who are, I'm going to go back to that, but I'm just going to say that there are a lot of women who are mothers. About 70% of the women who are involved are mothers, so there's a lot of mothers. Now, why did I get involved in this? There was a study done back in 2007 that showed, just prepare yourself for this number, almost 13 times higher risk of death for people who are released from jail or prison in the prior 2 weeks compared to the general population. So that's a huge, number. And, what are those reasons? So a lot of them are overdose deaths, also though cardiovascular, like stroke and heart attack, and unfortunately suicide and homicide. But of course, there are also great increases in HIV, and I'm going to talk about this. But one thing I just want to say is that in New York City, people who are sex workers who have condoms on them, like in their purse or whatever, can be arrested as sex workers. Now, this is just something to think about for a minute in terms of harm reduction. And I thought, maybe this was just a million years ago. But like within the last couple of years, when we had conferences in person, I asked people in New York, and they said, no, they're still doing that. So it's just a really shocking level of poor public health practices and stigmatizing, because basically they're saying, if you have a condom, that means that you can be acting as a sex worker, which is crazy. So generally, women tend to have fewer violent crimes than men, but again, highlighting that women are generally victims that are incarcerated, and they can be and are incarcerated if they're with a male or a partner or somebody, generally a male, who committed a crime. For example, one of my patients who was incarcerated for over 30 years was kidnapped and was with a man when he murdered 2 people, and she was a hostage of his, and somehow she was arrested and incarcerated for 33 years and just managed to get out recently. I know it's shocking. But so many of my patients tell me how many people are incarcerated who have, in self-defense, killed or injured a partner, an abusive partner. And when I talk about this with the district attorney, she feels like this is great because she's only prosecuting them for manslaughter instead of first or second degree murder. So again, this is what she considers to be progress, and this is what makes smoke come out of my ears. So generally, what I would say is that we're criminalizing trauma. Incarcerated women have much higher rates of trauma than the general population. And we know, of course, that people of color are disproportionately incarcerated. And if you look at these numbers, 49 out of 100,000 white women compared to twice as much and 1.5 as much for Latina women. And this is what I said already before. I was trying to run forward to this slide, but there it is. So what are the sequela of trauma? And we know what they are: PTSD, but also HIV risk behaviors, and that's where we get into HIV. And it's much harder to access healthcare, and that's why I do the work I do. So one of the things I would tell you is that we did a study of about 100 women who were in our program, and we found that 85% of them had not had a primary care provider prior to being in our program. So I'm excited to say that we've helped some of those people. All of these factors are associated with what we call recidivism, which is being rearrested, and are not routinely addressed. So they don't have trauma, what we call trauma-informed approaches generally when people are incarcerated, as they should. And the things that happen to people when they're re-entering after incarceration impact women differently. So a lot of people will we see a lot of women who end up doing sex work of some kind, whether it's for housing, for food, for drugs. Sometimes they're prisoners and being trafficked, and it's very, very hard and dangerous to break away from person who's trafficking them, because this is like a source of income. And so it's really, actually it's one of the hardest things, is to get people away from a trafficker. Also, they're asked it interferes with housing and education, and that a lot of times employment. So they'll ask that question, even though it's legally they're not supposed to be asking that question, but they'll still ask that question, have you been convicted or, of a felony or whatever. And then also, a lot of times they go back to an abusive partner for housing to have access to their children. So it's not just for housing, but that's where their children live. And their partner might have also been doing the same things they were doing, but for various reasons they might have gotten arrested, and so their custody might have gone to the partner, and then they're back there to see and be a part of their children's lives. Just something about stigma. Just remember that, if you talk to our public defender who, they're lovely people, they work really, really hard. Last time I spoke with them recently, like 95% of the people that are incarcerated are plea bargain. So we never assume that anyone's guilty, and we don't ask them whatever they got arrested for, because we assume that there's a good chance that they are not guilty of that crime, and in any case, it doesn't matter anyway. But just don't assume that people who are incarcerated are guilty of a crime. And a lot of times people who do the same thing just happen not to be arrested, and so much of it is about race and economics. And just know also that bail reform, which we have and people are trying to take away, is not for felonies. So, a bunch of us are actually observing the judges right now. There's this program that's going on that's very exciting, where we're observing the judges for inherent bias behavior, and we're going to be giving them feedback on that. So it's a really exciting pilot program. And we just see person after person come in, black men who've been arrested. And what was I going to say? I got distracted by the horror of that. They're all there for felonies, and they're being incarcerated. So bail reform does not cover felonies. So we also think it's really important about terminology, and I know this audience is very sensitive to terminology. So we are very careful not to say felons, not to say inmates, all these words that are just labeling and stigmatizing. So it's important that we say, incarcerated person, et cetera. So that's something that's important for us. And it may be, as you know, that person themselves might use that language, but for us, we still try not to use that language. So we always assume that incarceration is very traumatic, and we welcome people home. There's so much abuse that happens in incarceration, including studies that have shown guards, this is just so horrible to think about, guards, police officers, even judges who have forced sex with women, and also particularly transgender people are at very high risk, particularly transgender people of color are at very high risk of being sexually assaulted by people who have arrested them or otherwise involved, whether it's their probation, parole, et cetera. So it's very troubling. And the studies show that they do not use condoms when they do that, so they're putting their partner at home at risk as well. So these are all public health issues that are not, I'm sorry to say, being addressed correctly. And in jails, and we talked just briefly before about IV drug use as a mechanism for AIDS transmission. And one thing that's very strange is that in the jails and the prisons, so you are, of course, not allowed to use drugs while you're in jail or prison. But the system will not really acknowledge that that's happening, and so they won't give out clean needles, and similarly will not allow people to have condoms. So, again, poor public health. In the state of New York, it's required now that they give medication for opioid use disorder. It's called MOUD. And we're trying to not also say MAT, because MAT is a more stigmatizing term. So I'm just introducing you to these ideas if you haven't heard. So we know that when people come out, one of the reasons for that high risk of overdose is if they go back to the level of drug use that they were using before they were incarcerated. And it's been shown that medication for opioid use disorder helps decrease that overdose death after release. So it's definitely a public health measure. And of course, if you're using the medication, you're not using IV, so that decreases HIV risk as well. So in the state of New York, it is now required that that be offered to people. One of the difficulties, though, is making sure they get it after release and making sure that transition happens. In Monroe County, they're doing really well with it, but other counties, they're still working on it. So I just want to talk a little bit about COVID. During COVID, we were supposed to have people expedited release from jail and prison. It was very difficult to do that. When we talked with our sheriff about it, he was really stuck because it was required to go through a whole chain of command, and he really didn't have control over it. They would get notified that a whole group of people were going to be released, and then they had to, release them with peanut butter and jelly sandwiches because they weren't even, provisions weren't even made for them to get food. But generally speaking, there wasn't a system to hold people accountable. So just so you see, for instance, so looking at the bottom, so in New York State, 10,000 people in prison with COVID, 44 died, 12,000 staff. So a lot of staff don't get COVID vaccines, and this is frustrating. I know there may be some people here who don't believe in getting COVID vaccines, but those of us in public health feel that it's very important and believe the evidence. And so staff and some of the people in prison and jails all had access to the COVID vaccine, but some people didn't feel trustful, which is understandable. I found this article in the New York Times that you might want to look at. It showed that the whole range of places of COVID from people who were incarcerated versus people in that state. And so in New York, it's actually not as bad as some places. So in New York, it was 10 out of 100 versus 16 out of 100, which is still a lot, actually, when you think of how many people are incarcerated. In Michigan, the difference between the general state and the prison was just shocking. 9 out of 100 people in Michigan got COVID versus 76 out of 100 who were incarcerated. That was the highest. So I found that article immediately when I Googled that question. It's very interesting, crazy. So as I was saying, it's MOUD, medication for opioid use disorder, is required. I have heard people who are in charge of the jails who have a lot of stigma against giving, as you were saying, stigma against giving medication for opioid use disorder to people. They'll say things like, they shouldn't be given Narcan, which we know helps decrease risk of death, because they feel that it just allows people to go to drug parties or whatever, or even that if they overdose, that they deserved it. So there are just a lot of really negative attitudes towards people who use opioids. And that law actually recently was passed, so that's exciting. So what are trauma-informed strategies? And some of you may already know this. Focusing on non-re-traumatizing, so particularly for women, having separate groups for the most part of various kinds, and then giving people more control. So, and some of you here may be health providers or work in the community, but control is really important for people who've had histories of trauma. Also, ensuring physical and emotional safety, and these are all things that have been shown to help people. And of course, jail and prison are the ultimate lack of control, so that's not good for people who have trauma histories. So in relation to HIV, when I think about that, we know that people who are hungry, who don't have enough to eat, and also these social services are, oops, that's my timer. Social services are decreased for people who have felony histories, so it's harder for them to get food, for instance, just a simple thing. And yet people who are lacking food, studies have shown, are more likely to engage in HIV risk behavior. So that's another public health issue. So, in relation to voting, which was raised, really important, we also know that Black women are at higher risk for acquisition of HIV as well as incarceration. Why might that be? It may be that relating to that question before of being sexually assaulted and also of their partners maybe having sex in jail, not allowed to get condoms, maybe they're in jail, not allowed to get condoms and clean needles. So these are all things that trickle down. And we know that access to medication differs for people, and that 13 times higher mortality rate I mentioned before has to do with how much access, in some ways, access to medication they have after relief. So, quickly, so in summary, there are many women who are involved in the criminal legal system, disproportionately people of color, disproportionately for women, lower level offenses, and related to trauma. And we know that stigma definitely impacts their health. And there's definitely a lot of overlap between risks for HIV and the criminal legal system. Varied availability of all of the things that help prevent. That there are standards, but they're not really accountable. No one's really accountable. And we as a community can certainly advocate systemically and as individuals, which I do. And we'll talk more later. Thank you. Thank you very much.
Thank you very much, Dr. Morse. And then I'm going to welcome our last speaker, which is Alexis Plus. And after Alexis will present, we will all come and sit and have a conversation. So Alexis Plus is a licensed professional engineer with over 25 years of experience in the design and construction industry. She's taught, she's worked, but the most important role she's had in her life is being the mother of 3 sons. Unfortunately, in 2014, she lost her oldest son, Jeff, to a heroin overdose. And a result of that experience, founded Truth Farm, a nonprofit organization with a focus on raising awareness, reducing stigma, educating, and advocating to reduce the harms caused by substance use. The organization is deeply committed to social and racial justice issues as they move forward in addressing the current overdose epidemic with the ultimate goal of ending the war on drugs. Truth Farm is a grassroots organization that has impacted legislation, the way our community views substance use, and has gained nationwide prominence and recognition. Alexis herself serves on a statewide coalition to end overdose in New York, and she's a co-chair for the New York State Harm Reduction Association. Her work is her therapy and allows her to fulfill her purpose in life. And I think that's pretty clear how she's managed to take something and create such change for good. So thank you so much for your work, and thank you for joining us here today.
Thank you so much. I'm the least fancy person here today. Let's see, there's a button presser here. Thank you. Okay, there we go. So a little bit about the history. That's, Benita mentioned my height. That's me with my 3 tiny sons. Always like cracking that joke. And I'm a structural engineer and also an artist. And this picture was taken in April of 2014. And 4 months later, I would lose my oldest son, Jeff, in the plaid shirt, to a heroin overdose. And I didn't know at the time that I really needed to do something about the issue. I was working on a construction job down in Baltimore. And there was like a Facebook group that was made to address drug issues in our community. I live in a really small town, Windsor, New York. It's like high school graduating class of like 70 students. It's like a really tiny town. So I'm in this Facebook group, and people, we all know each other, right? So they know that I'm in this Facebook group. They know that I've lost my son to an overdose. But the community members are talking about what we can do to address drug issues and overdoses. And somebody says, well, you know, what we need to do is to make sure that these parents know where their kids are and what their kids are doing. I was like, come on, you know me. You know how I raised my sons. You know that I was involved, like, you know. And then another person said, I think what we need to do is have the coroner come and bring pictures of the dead bodies. And that was kind of my wake-up call, that I had to do something, and that the way that people wanted to address drug use and overdose fatalities, I knew was wrong. I didn't know what was right yet. If I had known what was right, my son might still have been alive. But I knew that what everybody was saying was wrong. And so I kind of set out to try to figure out what was right, what would we need to do. So just to give you a little bit of an overview of how bad the epidemic is, I have 2 images kind of overlaid here. I wanted both because I like that the underlying image is from 1980 to 2014, and it shows the rise in overdose fatalities, and you see that that slope is nearly vertical. And then we had a little bit of a drop. It wasn't increasing as greatly. And then after COVID, as you can see, 2021, we lost over 100,000 people in the United States to an overdose. It is not the only way that we're losing lives. Sometimes I get a little bit frustrated that we're talking about overdoses only. We could talk about hepatitis C, endocarditis, HIV. I mean, like the list of ways that we're losing people. Incarceration is just incredible. But overdose death is now the leading cause of death in people 50 and under in the United States, which is pretty remarkable when you think about it. Skip that one. Okay, so in 2011, the CDC declared that, that overdoses were at an epidemic level. I feel really pretty pissed off every time I think about that, because at that time, death rates had tripled in about a decade. They have almost tripled again, and we're just not doing enough still. How do we compare to the rest of the world? I think that this is really an important slide. I try to weasel this slide into like every presentation I give. It can be completely unrelated. I'll slip this slide in because I think it's so important. But the United States, we're number one. We're losing 185, this is old, this is like as of 2016, but we were losing 185 people per 100,000 people in the United States. And then look at the rest of the countries. I like to joke that maybe the bottom half have a wall built around them, but no, that's just a bad joke. They don't. And in fact, Portugal at the bottom is one of the countries that led me to the belief system that I have now. So Portugal had their own overdose crisis, and they turned their overdose crisis around in the span of 3 years. How? A lot of you probably know, right? Decriminalized substance use. So they decriminalized drug use and actually made treatment readily available for anybody who wanted it. At any point in time, they could have treatment, like unlimited access to treatment. So Portugal completely turned their overdose crisis around, legalized drugs, and they have the lowest overdose fatality rate in the world. So as we can see, it is, oh, I should also mention the United States also has the highest incarceration rate of all of those, and it goes hand in hand, and I want to hang out with Diane. And so we know that the drug war is really what's killing people. I'm in Broome County, so you're going to see some references to Broome County here. Our county sheriff stated that he believes about 85% of our jail population are people who suffer from substance use disorder. He probably used way worse words than that, but that's what I put there. And in the United States, nationwide, they say about 65% of the jails and prisons, those who are in the jails and prisons, meet the medical criteria for substance use disorder. So there are stigma parallels with the AIDS, HIV epidemic, as I'm sure that you all recognize immediately, and I wanted to throw a few slides in showing that. Sometimes I can't believe these are in our lifetime, right? The headlines are just incredible and horrific to look at. So this was during the AIDS epidemic. However, as bad as they are, here we are in 2010s, 2020s, with the same type of language and the horrific label and stigmatization of people who use substances or have overdose. Junkie, we still see in headlines. And even people calling for things such as like the 3-strike rule, where they wouldn't give Narcan to a person more than 3 times, because if they had already saved them 3 times, that was enough. So horrific stigma related to substance use. And I believe that it's a lot of the reason why we didn't make progress during the AIDS epidemic that we should have. Like syringes should be decriminalized nationwide at this point, right? I mean, we knew during the AIDS epidemic that this was a public health measure, and yet we still have many states where it's illegal. We just decriminalized syringes in New York State this past year, which is wild, right? Drug prevention often looks like this, which is absolutely ridiculous. And it's not gotten all that much better today. We also see stigma in the public. This was from a few years ago. This woman started a petition that she wanted to have people criminally charged if they overdosed and EMS was required. And she had like thousands of signatures on this petition. It was really wild. That image is just a little bit of a tongue-in-cheek. Sometimes Truth Farm, we do like a little bit, maybe a little mean-spirited, I don't know. Picking on some people. So this was actually our Broome County Mental Health Commissioner. He has since retired. I might have driven him to that. But we were calling for our county to issue warnings when there were spikes in overdoses so that people would be more conscious and go slower and use more carefully. He actually was quoted in the paper as saying, the warning is already out there, don't do heroin. That was his solution as our county commissioner of mental health. So we made this cute little social media poster for him that said, just say no. And we recognized at Truth Farm really early on the parallels to the AIDS epidemic, and then also that we were surpassing it. So in 2015, I created this chart that showed that the overdoses were rising. We were at 43,000 overdose fatalities per year in 2015. As I mentioned, we've doubled that already. And that has now surpassed the peak of the AIDS epidemic. And now we're at double that. More stigma examples I like to show. 2016, and actually this hasn't changed all that much since 2016, unfortunately. This is actually the discharge papers for a young man who had overdosed and went to the emergency room. And the diagnosis is intentional opiate overdose, which is horrific because, of course, it was not intentional. And then discharge instructions, you gotta love this. Please stop doing drugs. You were almost dead today. You could die from this in the future. And follow up with your primary care. So not incredibly helpful. It really hasn't changed all that much. I'm sure that there's certain hospitals who are doing a much better job in terms of addressing overdoses and addiction. I can tell you at our local hospitals, they're still not doing all that great. And there are appropriate responses. This is obviously not it. And then, of course, families are encouraged to walk away from their loved ones. You know, this is like the person was told, walk away, I'm tired of the stigma, let them die, is, you know, what people are saying. I forgot to mention in the first slide with my three sons, two of my three sons struggled with opioid problematic use. Two of my sons were also incarcerated, of my three boys. I was told constantly that I just needed to walk away from my sons, which is just wild to me, that anybody would think that that's a solution to somebody's health issue. And then we had this meme in 2018 that again talks about we need to end the war on drugs, and it talks about Portugal and the decriminalization of drugs. The final line here, but I fear that until the big dog in this war, the United States, decides to call it quits, we can expect more death and destruction for quite some time. And that is absolutely the case. So I truly believe the solution to the overdose epidemic is ending the war on drugs, without a doubt. The truth is people are not getting care or treatment even when they desperately need it still. It's kind of like, it just blows my mind. Here we are 11 years after the CDC declared this an epidemic and people still cannot get the treatment that they need. This one in this case was the insurance wouldn't pay for longer treatment. And then they expect the person to just assimilate back into real life and be successful in recovery, which is just ludicrous. Same with incarceration. People are just expected to survive, and it's just not working that way. And in the United States, still only 1 in 10 people who have substance use disorder can obtain the type of treatment that they need to recover, which is just an absolute embarrassment. So when I started this organization, first of all, I'll tell you with a little bit of an embarrassment, I didn't know I didn't even know there was a thing called harm reduction. So we based our principles, I gathered community members, other people impacted by overdose and loved one substance use disorder, and people who had active addiction, and we developed our core values. And we just believed that people should have basic human rights, which that shouldn't be all that hard to grasp. And then I found out a couple years ago, oh, there's a thing called harm reduction, and that's what we were actually doing and believing in. We call our volunteers who are highly involved in our organization rainmakers, and the majority of them are impacted by substance use disorder in some way, whether it's themselves or a loved one, or they're in recovery, or they've lost someone. I pulled a lot of these slides from a presentation that I made probably 4 or 5 years ago with my vision for what Truth Farm would be. And so it was kind of fun to pull these forward and see where we are today. We believe in having bravery in confronting the issues, the discrimination, the lies, and the failings of our government to care for those who need help, treatment, harm reduction programs, and non-discriminatory practices and policies. This is from a rally back when we could still have rallies before COVID. I think this might have actually been right before COVID. It might have been 2020 or 2019. It was an incredible rally in Albany. And then the Trail of Truth Benita mentioned, and so I'll go into a little bit of that even though I'm almost out of time. So when I started Truth Farm, February of 2015, I realized, as our county was releasing overdose fatality numbers, they seemed wrong to me. And I just kept paying attention. I was like, no, everybody, because now people knew that I was doing this, so people were contacting me like, oh, so-and-so lost their son, or so-and-so lost their daughter, or this person, whatever. And we live in a small county, so when the county was releasing their numbers, I was like, something's wrong here. I just don't think this is accurate. So we decided to start tracking the overdose fatality numbers ourselves. By August, it was kind of funny, you can look this up. By August, it was kind of like dueling press conferences. It was like Truth Farm against the county health department. So we'd have a press conference and say, look, we had 30 overdoses in our county. The county would have a press conference, and that's even quoted here. They said there were 11 overdoses in July, right? We thought that there were 30. So I was like, the county's lying about this, and they're erasing our loved ones, and I didn't know the purpose of it. It was infuriating to me. And so I decided we're going to have an event for International Overdose Awareness Day, and I'm going to have every family who has lost a loved one send me their name, their information, their picture, and we are going to, you'll see in a minute what we did. We're going to show the county you can't dismiss people when you see their faces. You can't erase our loved ones anymore. We had a new DA at that time who took interest in this, and he decided that he would investigate and see how many overdose fatalities there were in our county. And he released the number just before our Trail of Truth, and it was 53. So our county had said, at that point, by August, they had said there were 16 overdose fatalities in the county, and there were 53. So our Trail of Truth was in direct response, and it was activism in response to our county not counting overdose fatalities correctly. We call it a live performance art piece, using the family members to memorialize actual lives lost. And it was a presentation that couldn't be denied or ignored. The county still tried, just as an FYI, we hosted this, and Benita said, about 100 people showed up. It was an incredible, beautiful event. I'm also a street painter, so I use high quality chalk, so we did the chalk outlines, and then we wrote the names of each of the loved ones lost, their ages, and the dates that they had passed away, and then we let family members write things about their loved ones in the tracings to symbolize that they weren't just empty lives that were lost. About 5 p.m., the county sent out county employees to scrub and clean the images off the sidewalk. I was so pissed off that I issued a formal letter and said, we're going to redo it every week until they stop erasing our loved ones, and we did. Thank you. The next week, we did it, and they didn't erase them, and so now we just do it every year. So the goals of the Trail of the Truth, actually I'm way over time, so I'm just going to go through these pictures really quick and not read all the stuff. But these are just images from the Trail of Truth that are pretty incredible. One of the things that I want to mention is that direct rage, number 7. When people lose, when somebody loses a child, I think there's an 8th stage of grief that people don't talk about, and I call it somebody's going to pay. And it's something about losing your child that just makes you feel like this is so wrong, someone has to pay for this. Unfortunately, a lot of times the anger is very misdirected. Most frequently, it's directed towards the drug supply or the person who supplied the drugs. And so we work very hard to try to redirect people's rage towards the things that are more correct, which is bad public policy. These are just images from the Trail of Truth from over the years. We bring artists together. Anybody from the community can come and paint the tombstones ahead of time, and then we all gather for the Trail of Truth. I would love it if you all come. The one picture in the top left, during the Trail of Truth, we call up people who have survived overdoses. By having Narcan administered to them. It's always a moving and powerful moment. We celebrate them, hug them, give them a gift. We just tell them we love them, and we're so thankful that they're still with us. It's always beautiful. Little children come. It's really emotional and powerful to see little children memorializing their parents. This was from a couple years ago. Now it's just a huge event, and last year we memorialized 169 people, and it just looks like a sea of tombstones coming down the road when we march toward Governmental Plaza. I'm so much over time that I'm just gonna. We also do surveys and research to really put things in people's faces when they try to lie. So, and then we like to use art very much to speak to the public and to connect with them. And we've hosted a lot of art-related events. This was another act of protest. Our town has an event called Luma, and I wanted them to do a projection that was related, it's fancy, beautiful building projections. I wanted them to do one related to overdoses and addiction, and they said, we don't want our town known for that. And so in protest during Luma Festival, I got permission to project on top of the governmental federal building and projected images of our loved ones who had been lost all evening. So people saw it. People were pretty mad at me. Guggenheim, some of you might be familiar with Nan Golden and her work. Truth Farm participated. That's us in the blue shirts doing the banners up there. We participated in this protest at the Guggenheim calling for accountability with the Sacklers and Purdue Pharma. Just more images. We were successful in getting cannabis legalized in New York State. We played a big role in that last year. And then last year we also smoked weed in front of the police station on 4/20 to celebrate, which was pretty awesome. This is a list of some of our accomplishments, and then I'll leave this list up because these are things we still need to do, which is a lot, and I really did run way over time, so I'm sorry.
Wow, all right, thank you all, the presenters. That was amazing and really fit really as an amazing conclusion for this inspiring day. And Alexis really left us with a vision for future, so thank you for tying it all together. I think I'll open it because we have a limited amount of time. Let's open it to the audience and take some questions.
What's in the water in Broome County? It's interesting that you're both coming from that same place. Had you met before?
We met as a result of doing this work. Mm-hmm. Yeah. And Broome County's like, I always used to think Broome County was the worst of the worst, and then when I started researching about all of this stuff, we actually are. We have the highest incarceration rate in the state. We have the second highest jail death rate in the state, and we have one of the highest overdose rates in the state. So, yeah, lots of work to do in Broome County.
Sorry, I forgot to remind, just wait for the microphone to ask a question, so we're recording. Okay, yeah.
Hi, I missed some of I think the first speaker, the faculty or professor. What do you think what are some of the causation of the increase in overdose over the last maybe 5 to 10 years?
Well, I mean, okay, so we have to separate out the past couple of years. Clearly, the COVID-19 pandemic made things worse. Let's put it this way, solitary confinement is punishment for a reason. People who have substance use disorder or are in recovery, solitude is usually not their friends. And we all had to hunker down and isolate. Prior to that, I mean, I can talk to the sociological explanations that seem to be out there, or I should say the social science explanations, which have a lot to do with the decimation of the working class and the middle class, increasing precarity at work, the inability to really rely on remunerative work that will actually let you live your life with a living wage, right? There's economists, I don't like this phrase, but there's economists that talk about the overdose crisis of the past, again, 10 years or 15 years as being deaths of despair. Again, that's their word. There's something to it. It's perhaps not, for me, not as precise as it could be, particularly in class terms. And I'll pass it to you to say, because I think you know more about this than I do in terms of the causation.
So another big contributing factor, so there was the over-prescribing of opioids, right, which led to this explosion in dependence to opioids themselves. The United States, has about 5% of the world's population, and we consume 80% of the world's medical supply of opioids, which is wild, right? So when the overdose epidemic first started, and I want to say the activism that was beginning even before I lost my son, a couple years before, about 2012, was a lot of parent movements. Unfortunately, a lot of them were like anti-opioid. And while I believe we need to hold bad actors accountable, like Purdue Pharma, the Sacklers, and all of those, I believe fully that we need to hold them accountable. The knee-jerk reaction of our government was to, tighten up the prescribing of opioids without providing a solution for those who were already dependent. Mm-hmm. And I remember back, this was like early 2015 when I first started Truth Farm, they were saying how they were clamping down on prescribing, and there was an article where they even said, this may lead to more deaths. And I was like, what? Am I allowed to say the F word here?
Yeah.
I was like, what the fuck? Yeah. Okay, so you're setting people up to die, and you're not preparing for that, which is just wild. So they just clamp down on prescribing by the doctors rather than giving the doctors a tool to help people out of opioid dependence or to help them with it. So clamping down on the opioids actually increased our deaths because people were turning to street supply. And then heroin production, we didn't even have enough heroin to go around for the amount of people that were addicted, and then enters fentanyl. Right. And so fentanyl is now the leading cause of overdose fatalities in the United States. Things have changed so much. When I lost Jeff in 2014, more people died of prescribed opioids than all other drugs combined. And now more people die from fentanyl than all other drugs combined. So that's the switch that we see, right? We knew that we need to do something about the over-prescribing of opioids. The problem is we didn't have a solution for people who are already dependent.
I just want to add a couple of things to that. One is that, yes, fentanyl, and that fentanyl is in all the other drugs. So it's in marijuana. Right. We've had marijuana fentanyl deaths in this county, and cocaine. And then people say, well, why do they do that? Why do the drug dealers do that? And I think it's just good to know that why they do that, which is to get people addicted, because then they'll keep using it, and it's, you know, it's a sales thing. And then the other reason I would say is really important to understand is racism, because actually a lot of people think that it's really more of a white person epidemic, but there are actually higher rates of overdose nationally among people of color, and more stigma, more discomfort, more mistrust with the medical community. So that's another reason.
So I actually lost a friend to overdose in April of 2020. So right after I was a senior in high school, she was a sophomore. And so I was curious just how advocacy has changed as a result of the pandemic, and also what kind of new concerns that you might be focusing more on now, kind of pandemic shutdowns and things like that, like what you were focusing on at the height of it, and now that people are saying COVID is over and kind of looking forward into the future, what kind of new directions you're working in from things that have been raised because of the pandemic.
I hope I heard you. I hope I heard everything correctly, but I think that you asked about how COVID impacted our advocacy and where we're going with it from here. Okay. So COVID was a real drag. It was really difficult. I mean, it's been really frustrating. The Capitol is shut down, and we have Zoom meetings with our legislators. I can promise you they're not as powerful as meeting in person. You can't beat that for advocacy at our Capitol, and you know, we just can't do the same type of work under the restrictions of the current pandemic. So it's been really frustrating. It has slowed us down significantly as a movement, as an organization. It's also hard to get people excited. You know, people who have a limited amount of capacity for concern for things, right? Yeah. So it's like, it's hard, and it's been really sad and hard for me to figure out how do we get people back to thinking about the overdose epidemic, because people really did lose interest when it was before COVID, like the overdose epidemic was the thing that everybody was talking about. And then since COVID has hit, it's really hard to get people to even think about this. I don't have the magic wand or solution to that yet. I'm trying to figure it out still. It's really frustrating. I mean, you know what, it's kind of like the example of when the headline came out that we lost 101,000 people to overdose, and I was like, why aren't we in the streets? Why aren't we in the streets, you know? But it's like, we're in the streets for so many things right now. There's so many things like just fucked up in the world that like we're constantly out in the streets, and everybody's it's compassion fatigue and all sorts of things. Hopefully we figure out how to elevate the issue again and get people concerned about it so that we can turn things around.
I would just also add, and I'm so sorry for your loss. It makes me sad to think about it.
Yeah, it's very young. I'm sorry.
Very sad. In Monroe County, we're doing a lot of things well. There are things we could do better. One thing I just want you to know that there is our sheriff, who is a really good person. He appointed a police officer whose entire job is to go follow up on all the people who've either had overdoses or died of overdoses, like so even surviving an overdose, to go to their homes, because they don't have HIPAA, so they can do that, go to their homes and talk to their family members and drive them to treatment, He never arrests anybody. His entire job is to go to people's homes and help them. And I've actually had some patients of mine who, for whatever reason, didn't want to talk to me and wanted to talk to him. I think, having a breadth of resources, because everybody's going to feel comfortable talking to a different kind of person. So having him, also we have in our health department, similarly, a lack of HIPAA, so they get the names of all the people who have overdoses, and they have peers who also go to people's homes. We have an entire opioid task force that meets every other month, and it's multidisciplinary, and we all, talk about all the things that we can keep doing. So I would say more of what's needed is getting people to treatment, because part of the problem now is that we have outpatient treatment, but a lot of things are understaffed right now because of COVID. So I think, if you know a person who doesn't have a job, encourage them to maybe go into healthcare, because there are a lot of unfilled positions in all of the substance use agencies right now, outpatient, inpatient. It's harder to get people into those programs, although it's better than it used to be. So I think, as we recover from COVID, getting more people out on the job, having better childcare so that people can go to work, and then helping people feel more trustful of the healthcare system so they go to treatment.
Thank you all for your work. I'm just wondering if, given the traumatic impacts of incarceration that you've all discussed, if what you see as the role of the prison abolition movement, if that plays a role in any of your work or your advocacy?
Sure, of course. I would say yes, definitely. And also legalization or decriminalization, but in this case, legalization of marijuana is a part of that. And also at the same time, supporting people who were impacted, right, by being arrested to help own some of those dispensaries is really important. So definitely abolition is important, and I think that advocating for the bail reform law is really important, and also there's some new, there are just a whole lot of different advocacies that we can do, different laws that are coming through. There's an article that I was quoted in recently in the DNC where we're advocating for people having their crimes, erased after a certain number of years. And I guess my feeling is yes, but also we can't wait for that, because still it's going to take time, so we have to keep working with the system that we have. So that's what I would say. It's like both yes and.
And I think, for me, I think of abolition as a practice, as a principle, as an ongoing commitment. We're not going to wait to dismantle all the structures of oppression, but we're going to actively take steps that get us closer to that in every point in the way. My own research works on child protective services, and I call it abolish child protective services. We don't need more investigation of families. We don't need the family policing systems. We need systems to help families thrive. But until we get there, how do we think about what families need? What do mothers who use drugs and then get drug tested and get referred to child protective services? A child can be removed from their home, or a baby can be removed from their nursing mother without any harm being done apart from by the action. And I think I use this as a guiding principle, thinking about abolition, thinking about replacing this instead of the structures of punishment, and completely rethinking our relationship with both substances and how we approach people who use them, and ask, what do people need in order to meet their full potential? What do people need in order to thrive, rather than what is the one thing we can do to punish, restrict, regulate, instead of the thing that we already have, which is clearly failing.
Yes, we are abolitionists.
Thank you so much, everyone, for your work and for this panel. I wanted to actually build on Michael's last question about thinking about child protective services, and I wondered if, and maybe this might be a question for you, Alexis, I wonder how you're thinking also about child welfare services in relationship to harm reduction, because my understanding is that that substance use is often one of the major reasons that Child Protective Services use to remove a child from their home. And so I wonder how you see that connecting here.
Yeah, we do a lot of work in this area. We are on some coalitions trying to get some laws passed, such as like prior consent laws, to make sure that mothers who are pregnant or in the hospital give consent before they're drug tested, because that's a really terrible practice to drug test a woman and then take her infant child from her in a lot of cases. And we do a lot of individual advocacy for people who are impacted by the family regulation system. So we see it as very harmful. We know that people, well, like, look, the reality is, like, middle-class women use drugs all the time, right? They're prescribed by their doctors. So how is that any different than people who are using drugs that are less regulated or less prescribed? And their children are rarely taken from them versus people who are either lower income or a different race or whatever. So family regulation system is incredibly harmful. We believe that people should have the supports that they need, and we believe that people can self-regulate. Of course, you know, are there some problematic situations? Sure, but those are the, you know, we can change the system. Again, we are founded on abolition principles, so.
And sorry. Well, I was just going to say, I keep finding myself following after you, but I would just say that, you know, there's evidence that people of color are much more likely to have their children taken away. And also, I see all the time that people who, this is a very dysfunctional system, because people who have their child taken, their child might go to somebody who's also using drugs, alcohol, whatever. It's not a safer solution.
Yeah. I think a very powerful statement to remember is that a drug test is not a parenting test, and that people use substances for many reasons. And the same doctors who order a urine test on their patient without consent go home and sit with their Etsy Tumblr that says it's wine o'clock somewhere or something. And we all have relationships with substances, and we use this to criminalize and to regulate behavior of certain people we consider undesirable. And I just want to call some historical parallels, and I don't know if Professor McCune is still here, about how mothers were blamed for transmitting AIDS to their children when they weren't tested, when they weren't offered treatment, when they weren't offered the resources they needed to protect themselves and their children. And in the same way, mothers are blamed for their use of substances while they're pregnant, when a majority of places do not take pregnant mothers, when there is a dearth of institutions that will treat women who are pregnant, when some treatments that are evidence-based, including MOUD, in some states are considered abusive. Like if you're taking something that's prescribed by your doctor, that's still, you can still be punished from that. So, and we have a tremendous history of blaming mothers for societal failures and for punishing mothers for their behaviors, which are evidence of larger social ills, and certainly these parallels are very clear.
Yeah, I just want to say, though, that it's not always culturally informed, but in our substance use programs, the women that are pregnant are put to the very top of the list in Monroe County.
And I think that's awesome. I'm talking nationwide, and I just want to say, you do such amazing work, and everything you tell us is just, you know, thank you for what you're doing, and the things that are happening here can be really an example of how things could be done differently, and I wish they were. But the reality is, in many pregnant people struggle throughout the country to get the services they need. Thankfully, that is less the case here.
Right.
Thank you, Dr. Morse. What are we doing for time? I think we have room for one more question before we have to. Yeah. So, what's that? So if not, I will ask one last question. If somebody has any kind of summing it up, learning from history, there's a lot of things we didn't learn from history, and this, in some ways, this feels like a panel of all the things we didn't learn from history, and perhaps opportunities we could have. But it does seem, maybe Alexis, in your activism and Benita, in your work, if there's something that you wanted to share with us that you do see as inspiring hope for learning from history.
So I'll just say, because I ended by dogging my students for being 20, really, is what I did. But teaching about it, I mean, you know, young people want to hear about it. You know, especially young LGBT people want to hear about their, I hesitate to use the word elders because, you know, no one wants to get old, but it's better than the alternative. And they want to hear about it. They want, you can teach the connections, you can draw the connections, you can make them excited about the connections. That is a job for teachers to do, and I think it's a job for teachers to do at very many different levels, not just at the university level. I really did mean what I said about the success of social movements being predicated on their erasure. I think somehow in the zeitgeist, maybe it had to do with like the 20th anniversary or 30th anniversary of ACT UP or whatever anniversary. There was an anniversary, and so there started to be sort of more media attention. And now you do hear a little bit more of the story of direct action, anti-AIDS activism. It's being inserted here and there. I think it's true that it's mostly being told as a story about, you know, streamlining, you know, the FDA's approval of drugs. That's for sure. But that's a wedge. That's a wedge into making things more open and questioning more of the systems that at least the young people I know are going to face. So.
Awesome. Well, I'm sure you all join me in thanking the panelists.
And
you wanted to?
I wanted to say something too. I just want to say that I'm part of I'm part of a program called the Transitions Clinic Network. That's where our clinic comes from, and it started out in 2012 with about 8 clinics across the country, and now we have 50. And these clinics are all made up of people who are doing the work that I'm doing, you know, working with people who are coming out of incarceration, addressing substance use, addressing HIV risk behaviors, addressing stigma, and access to care. So I think that's very helpful.
My apologies for cutting you off. And Alexis, I don't want to cut you off.
You're fine.
No. All right.
No, I guess the only thing that I'll say in closing for hope for the future is, you know, I think we need to be patient and kind with each other and educate the community, and I think it's possible. I'm a little uncomfortable with the direction that we're going in terms of like social media and how we're treating each other. Not even a little bit uncomfortable, I'm way uncomfortable with it. And I know, like, we do our work in Broome County, this very conservative county, highest incarceration rate. And we have 12,000 followers and family members who are marching to end the drug war and who believe in like anti-racism now, things that they never would have considered in their lives before. And I think that it's possible to help people along and to teach them, and I think it's our job. So that's it.
I think all of you here are another avenue of hope.
Thank you so much. Thank you all to the panelists.
Great. So for those of you that joined this afternoon, my name is Tamar Carroll, and I'm in the history department at RIT. I would like to thank my conference co-organizer, Stephen Vider, and I would like to congratulate him on the publication of his new book, The Queerness of Home, Gender, Sexuality, and the Politics of Domesticity After World War II by the University of Chicago Press. Yay, Stephen. That book contains fascinating research on the Gay Men's Health Crisis Buddy Program, which is a really important example of grassroots activism that help people live longer and better lives, people that were suffering from HIV and AIDS. I would like to thank all of the presenters, all of whom were fantastic. Thank you so much for being willing to share your thoughts and your work with us today. Thank you to the audience for coming. Thanks especially to Memorial Art Gallery for hosting us and putting on this beautiful and important exhibition. The MAG staff have been amazing to work with on planning this event. In particular, Niall Blunt, Chio Wayama and Chris Garland, thank you all so much. Thank you to the ASL interpreters for making this day accessible. Thank you to the RIT Museum Studies students who volunteered as microphone runners. Thanks especially to Jessica Lacker-Feldman for helping me put on a satellite exhibition of AIDS education posters from the Atwater collection at RIT's University Gallery, where it will be up through April 8th. And it has some of the same posters as the exhibition here at MAG, but some different ones too. So I do hope you'll come check out that exhibition if you're able to. This is just really exceeded my expectations in terms of the thoughts that these conversations have stimulated, and I'm very, very appreciative to everyone who shared. Natalie, I didn't get to say this to you earlier because we ran out of time, but when you were talking about your dad saying it's important to be proud to be Haitian, you know, like under the Clinton administration, Haitian immigrants were detained on Guantanamo and subject to forced HIV testing, right? So there's, you know, and so many of you have shared how these issues of stigma, of racism, of HIV, AIDS, incarceration, opioid use disorder, they have touched, you know, so many people. And so thank you for sharing those personal stories. And I have to say, because of hosting the exhibition at RIT, people have been sharing personal stories with me, including the president of our university who had a family member who lost their partner to AIDS. And so I just think when we share these stories, right, we affirm the value of human life and everyone's life. And it's just really very meaningful to me personally. And I'm very deeply grateful for all of you. In Abram's book, he writes, while there is suffering, political resistance is a project every one of us is responsible to take up. And Dr. Morse and Alexis, I mean, you have clearly laid that out for us today and how important it is, and many of the other speakers as well. So I hope you leave today feeling inspired. And I'm going to turn it over to Stephen, but I also wanted to make sure that I thanked Mikal Raz and Jessica Latcher-Feldman, who are also part of Stephen and I organizing this conference. Part of it was getting funds from the Central New York Humanities Corridor, to whom we're very grateful. And Mikal and Jessica were part of our team in applying for funds. So thank you for that, and thank you to the Central New York Humanities Corridor, also to RIT and to the Cornell University Public History Initiative for additional funding support, and to MAG for all of the support they raised for this exhibition and for being able to provide free admission to all of us today. So thanks so much, everyone.
Thanks, everyone. I just wanted to just speak for just a little bit before I turn it back to Tamar to wrap things up. First, I just really also wanted to start by thanking my co-organizer, Tamar Carroll, for working on this working on this conference with me in conjunction with the exhibition. This conference has really been 2 years in the making. And basically, as soon as I arrived at Cornell, I reached out to Tamar to talk about doing a conference and a workshop in conjunction with the exhibition. We actually had to apply for the funding twice because the exhibition was delayed because of COVID. So it's been a kind of long journey to get here. And I want to say also just that what a pleasure that has been to have an opportunity to work with Tamar as someone whose work, both her scholarship and her curating work, I've admired for a very long time, and such a real pleasure to get to do this with you. I also want to thank all of our panelists. I especially want to thank Michal Raz, who was also one of our important connections to the University of Rochester and for leading the panel, and Jessica Lacker-Feldman for also being our connection on the proposal. I also want to thank you, Jessica, for your work curating an incredible collection, and Donald Albrecht for curating an amazing exhibition that is the occasion for us to be here. I mean, I want to say generally just how kind of moved I am by all of the conversation that we've had today. But one of the things I was thinking back to, in 2017, I curated an exhibition at the Museum of the City of New York called AIDS at Home, Art and Everyday Activism, that traced how AIDS activists mobilized home spaces in responses to HIV/AIDS from the 1980s up to the present. And one of the things that really became clear to me in a new way in working on that exhibition were that the challenges that activists in the 1980s were targeting around silence and stigma were the same exact challenges that activists working on HIV/AIDS today are facing still. And I hear those resonances also in many of the other social challenges that were identified and talked about today around incarceration and around harm reduction and substance use, right? That the ways that silence and stigma challenge us, right, to even begin to address them, and the work of grassroots activists to challenge that silence and stigma and make more space to talk about the people, right, who are facing these challenges and give them space to be seen. One of the things also that really has struck me walking through the exhibition was that some posters were created by activists, right? Posters like the posters by Grand Fury, by activist groups in Boston, right, and all throughout the country and the world. And some were created by public health agencies, right, and created by cities. And looking at that, I think it's really striking the kind of actual slow evolution, right? That I think today, public health organizations in places like New York and Philadelphia are much more kind of in touch with grassroots activists to create public health messaging that's more affirming, that's less fear-mongering. But that was not always the case. And I think about that in reference also to the ongoing HIV/AIDS epidemic, but also in regards to challenges around COVID and the ways that there were, I think, a lot of comparisons, of course, troubled comparisons to the history of HIV/AIDS, the ongoing history of HIV/AIDS and COVID. But I think that one of the themes I think that we need to keep thinking about is about the accountability that we expect from government and from our institutions to provide care. And what I feel like we're seeing now is a real privatization of care around COVID, this feeling that we are on our own. And I think we have seen that story of being on our own play out in relationship to HIV/AIDS as well, in relation to harm reduction. And what I hope that we see as what is possible, right, is about the kinds of grassroots activism and the kinds of connections that are possible between scholars and communities, between curators and communities, that begin to actually to be able to have an understanding of history that actually can inspire us to ask for care and create new models of care, right, at the intersection of communities and government. What I think that I hope that we have seen, right, is in this panel today that I have really seen, again, is the ways that these themes of silence and stigma, right, that they are in the past, but they continue. And that looking at the exhibition, again, why we are here, right, so looking at the exhibition, I think what we can also see is the ways that this provides this history and art and activism that the exhibition traces provides lessons and models for us to build from in the ongoing work that we all need to do. So thank you all again for being here and for being part of this conversation today.
Thank you, Stephen. It was also my great pleasure to get to work with you on this. and we'll have to think about what we want to do next. But for all of you, I want to let you know that tomorrow we are having another conference here. It's called the Rainbow Dialogues. It is a partnership between the Rochester Public Library and the Out Alliance. This is our 5th year having the Rainbow Dialogues as a LGBTQ public history event that celebrates the preservation of significant archival collections and also oral histories related to Rochester's LGBTQ past. It is thanks to Evelyn Bailey, who has spearheaded the movement to preserve this history and is the founder of the Rainbow Dialogues. So this will take place tomorrow. It is free and open to the public. And you can hear Jackson Davidow give the keynote tomorrow morning. He will be talking about research for his current book project, which is titled Epidemiological Art History, a Global Account of AIDS Cultural Activism. And so that will be a really wonderful talk. I've heard Jackson speak before, and he is a wonderful speaker. And I'm really looking forward to it, and I hope some of you can join us for that. And then we also have a panel on living with HIV/AIDS, in which participants will discuss, what it's been like for them living with HIV. And there will be time again to see the exhibition. So I know we didn't have as much time today maybe as it would have been nice to allocate to seeing the exhibition. So please consider coming back tomorrow and taking it in. And it's up here through June 6th. So spread the word, bring your family and friends, and let's hope that we can use this to educate people. And as Stephen just said, to find models for the future and to work on creating a more just world that we'd all like to live in and leave as a legacy for future generations. Thank you all so much. And the museum is open till 5, so there is a few more minutes to go back into the exhibition if you would like to do that now. Thank you.